Okay, today we're going to be covering a trauma assessment, a rapid trauma assessment. Here in Greenville County, here lately, we've had a lot of vehicle versus pedestrians. You need to know how to treat these patients appropriately in the field and get them to the surgical intervention that they need in the Level 1 Trauma Center. So, the treatments that I will do with this patient, I'll just be showing the assessment phase. I won't actually be showing you how to do each skill. I will verbally say what I would do at that point and continue on with my assessment and treatment of the patient. So a lot of things you're not going to see as far as the exact treatment. Well, we'll break that down later and have little videos of that as well as for each little treatment that we should do with this patient. I've arrived on scene and I've determined this is my only patient here. Automatically off the bat, I'm going to need some more resources. This is a massive trauma patient here and we need to get him to the hospital as quickly as possible. As I'm approaching my patient, I see that he has a complete amputation of his left arm that needs to be treated from the massive hemorrhage that we see. The only way to control this, pressure is not going to help, so we're going to have to apply a tourniquet at this point. I would apply a tourniquet and make sure that we stop this bleeding. If we don't, we're not going to have a survivable patient. Once that's controlled, then I'm going back up. Okay, as I approach the patient, I'm automatically going to take C-spine. And I'm going to see if I can establish some responsiveness. Hey, you okay, sir? Can you speak to me? Can you open your eyes? He does not respond, so we have to elicit some type of painful response. The way we could do this, maintaining C-spine, is either pinch the neck, pinch right here on the shoulder to see if we get a response, or take your knees, hold the patient's head, and maybe do a deep sternal rub. So the patient does not respond, so he is unresponsive. So we're going to have to establish an airway as well. So with my hand still on the patient's head, I'm able to palpate to see if he has a carotid pulse, and I do feel one. It feels about the rate of about 120. As well, I can feel the skin color and condition here. It feels like he's a little cool. I see some clamminess to his face, and he appears pale. And I can see my major bleeding down in the length of his body at this time as well, if we need to control any of that. So we're going to insert an OPA here to see if he accepts it. Then we're going to take a BVM. We're going to begin to ventilate the patient with high fluid tube attached at 15 liters per minute. Finally, I'll have a first responder when they arrive take over C-spine, place a C-collar on the patient, continue ventilating the patient, and then I'm going to do a rapid assessment to see if I see any other life threats. So we have to expose our patient. We immediately cut the clothes off. We've already treated the life threat over there. We've seen evisceration here. The way we're going to treat this is with a sterile, moist dressing, and then inclusive dressing over top taped onto the patient themselves. Do we see anything else on the chest? We noted a little laceration here, but it's a little oozing on the neck. But it's still considered a chest injury. So we need to apply an inclusive dressing as well up here on the neck on this laceration. We see if we have equal chest rise and fall here, and note any other injuries that we may see. We're going to check the pelvis to see if it's stable, the genitalia to see if we have any priapism, any incontinence. And then we have to expose the lower extremities. And we begin to look down to see what we find. Bruising, not a life threat. We're going to skip this. We find several lacerations to the foot that are open. Do we have major bleeding here? Is it arterial or is it venous? If it's arterial, we need to control with pressure. If that doesn't work, we apply another tourniquet. We move on to the other side. And this is why you do your detailed rapid assessments. We find that we have another complete amputation of the lower extremity. We try to control bleeding with pressure. Does it work? Remember, we go with a tourniquet. Bleeding is controlled. The amputated part needs to be transported with the patient, so we need to package that appropriately. Have fire or someone else package that. As well, look for the other extremity. If you can find that, then we'll transport that with the patient. If not, you leave scene, have someone find it, and then bring that part to the hospital later. Okay, we're still looking for life threats. Whoever has control of the head, on their count, 1, 2, 3, roll. We're going to roll up. So 1, 2, 3, roll. We start at the top of the head, the back, the neck, all the way down the back of the body, down the lumbar section, the buttocks, in each extremity to see if we see any life threats. Look at your hand, see if you see any blood. Where is that blood coming from? Look and see if you can find, is that blood from the other amputations or is it somewhere else? We're going to secure them in with our straps. We're going to pad all our voids. We're going to cover them with a blanket to keep them warm. We continue ventilations with high flow tube. We're going to try to obtain a sample history from anybody that's on scene. Any allergies, medications, past pertinent history, last oral intake, events leading up to exactly what happened, and get that information if possible before we leave. We're actually in the ambulance now going to the hospital, so we're going to focus on our secondary assessment. Being a little bit more detailed, looking for any secondary injuries, any other life threats that we need to treat, and looking at our intervention. So we're basically doing a complete reassessment again of the patient, which we should continue to do throughout the transport to the facility. So I'm going to start off at the head. I'm looking for that DCAP BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling as we do this assessment. So we start on the scalp. We have to feel. You always look at your hand to see if you have any more blood on your hands. If so, is it from one of the original injuries or one of the ones that you can see, or is it from one that you cannot see? And you may not be able to locate that, but you want to make sure there's no massive hemorrhaging. We're going to look at the eyes. What is the pupillary response? Are they equal and reactive, dilated, constricted? And note that in your documentation as well to the medical facility staff. We look in the nose, same thing. If we have just some oozing blood, we're not going to pack the nose or anything, or put a nose clamp here unless we have extenuating hemorrhage. But the thing is, this patient's supine. If we have a lot of massive hemorrhaging here, we're going to have to use some type of suction maneuver to get that out, or we're going to have to log roll our patient up. We're going to look in the airway, make sure there's no obstructions in there, dentures that have broken, anything like that that would cause a potential obstruction. Look for other injuries that you may see and treat those. Earlier we put an occlusive dressing here. Is that occlusive dressing still working? We're looking for trachea midline, tracheal deviation, JVD. We go down the chest, we're palpating. Remember, you have to put your hands on the patient. Feel these areas, making sure you don't feel any crepitus. Remember that DCAP BTLS. You're going to auscultate for breath sounds again. Are the breath sounds equal? Do we have equal chest rise and fall? Is that oxygenation, or shall I say the ventilation that we're performing on this patient, is it adequate enough? Is it at the right rate for this type patient? We continue down the chest, palpating. We look at the abdomen. Is it soft, non-tender? Do we have any injuries? Do we have any DCAP BTLS? We look at this evisceration that we treated earlier with an occlusive dressing. Is that still working? Continue on down. Reassess your pelvis. Is it stable? Do you see any genitalia injuries? Anything that would be of specific concern here. Continue down each leg again, lower extremities here. Remember earlier we saw bruising to the lower tib fib area here, about mid-shaft. Do we have a deformity or not? And say if we did have a fracture here, this is the time, if you have time, is to put a splint on this. Appropriate splint, immobilizing the joint below and the joint above. Remember your pulse motor sensory functions before and after your splint. Make sure your tourniquet's still working on this side. Make sure the part that was amputated is properly packaged, and that should be going with you to the hospital at this time as well with the patient. Remember, now we have them on a spine board. We can't assess the back anymore. We originally did that on scene. So, because this is a critical patient, we're going to continue our assessment every 5 minutes. And what does that entail? What that entails is when you're reassessing the patient every 5 minutes, you're starting back all the way at the beginning. You're looking at your general impression of this patient. Do they look different now, better or worse? Or are they staying the same? So we're doing our trending. You go back to the head, you go back to the ABCs. Do we change the status? Is it a priority patient? Or can we downgrade? No lights and sirens. So that's what we need to look at. Okay, remember on our trauma activations, we need to call and alert the hospital as soon as possible, whether this is a level 1, a level 2 response, uh, what the mechanism of injury is, our GCS score, our airway, is it patent? Have you secured it? Are you having difficulties with the airway? Let them know if they're hemodynamically compromised and give them an ETA. If anything changes once you give that report, call them back and update them please before you get there so they're prepared.